Hi guys, this is a review video for Public Health Sciences for the Step 1 exam, and hopefully it'll be pretty short. The real thing with this topic, is the need to do practice questions, but we're going to start off by going over some core ethical principles, talk about confidentiality, accepting gifts. Then we have capacity and consent. There's a couple of situations you need to be aware of. Decision-making capacity, informed consent, consent for minors, advanced directives, alternative decision makers. Then we have communication, so interviewing a patient, establishing rapport, with some mnemonics we need to know, delivering bad news, and then just a few tricky situations, but it's worth looking at the entire set from first aid in that regard. And then levels of disease prevention, major medical insurance types of plans, medical errors, different types of medical errors, and then Medicaid versus Medicare. So it's not too bad. We're just going to get started, and we'll start with our core ethical principles. All right, so our first core ethical principle is autonomy. This is just, respecting patients as individuals, making sure to tell the truth, respect their confidentiality, respect their choices, informed consent, and respect the fact that they have the right to refuse treatment, provided they have capacity and they can opt out. All right, then we have beneficence, which just means act in the patient's best interests, do good, generally speaking. Non-malfeasance is the principle, really just means do not harm. The benefits of any particular intervention, treatment, care must outweigh the risks to harming the patient. And then finally, we have the principle of justice, which is to treat patients equitably and fairly. So triage patients, say you're working in an ED, you have an elderly man who is having a myocardial infarction versus somebody who's in there for, a little bit of joint pain. You would treat the person with the MI first and then get to the non-life-threatening joint pain. All right, so autonomy, respect patients as individuals, respect their choices, the right to refuse. Beneficence, act in the patient's best interest. Non-malfeasance, do not harm, benefits must outweigh risk. And then justice, treat patients equitably and fairly, triage patients. All right, so then more with confidentiality, we said this important part of autonomy in particular. So confidentiality, respect patients' autonomy and privacy. You can disclose information to family, to friends, if the patient is incapacitated or an emergency situation, if you believe that disclosing that information would be in the interest of the patient, right? It wouldn't cause the patient some emotional distress to, keep their family from knowing. And in that case, you would give them, just the status, patient is stable or not stable. But again, in an emergency incapacitated situation. But general exceptions are, you can violate confidentiality if there's the potential for harm to self or others is serious or imminent. Alternative means to warn or protect those at risk are not available, and disclosure would prevent harm. All right, so specific exceptions to confidentiality, we have this mnemonic called SAVED. S in SAVED is for suicidal or homicidal ideation, abuse, children, older adults, prisoners, right? You would, if you're the physician, you would report this abuse to Child Protective Services or Adult Protective Services in the case of older adults. All right, victims is V for saved, being saved. State-specific laws to allow physician to disclose info to protect potential victims from harm. Epilepsy, this is just keep people from driving, so anything that would cause danger to other people on the road. You'd have to disclose epilepsy and then disease. So specific diseases are reportable to the public health department. Questions will try to catch you on this because there'll be some patient who comes in with an STI and they're like, please don't tell my partner. And then, what you would do in this case is if it's a reportable disease like an STI, then you report it to the public health department and then public health department takes it from there. All right, so next up is accepting gifts. So this one is a little straightforward, I'd say. This is not the harder of the ethics questions, but basically you have to determine if the benefits outweigh the risks of harm, and by that I mean benefits to the patient or risk of harm to the patient, right? So just generally don't accept gifts that are inappropriately large or valuable. Don't accept gifts if the physician identifies the gift could negatively affect the patient's care, and then don't accept gifts that cause emotional or financial stress to the patient, right? So the example that we're often given for this is patient comes in, they give you a card, they have some homemade cookies, and then they give you expensive tickets to a concert. What do you do in that situation? Do you refuse everything? Do you refuse part of it? Generally speaking, you can accept the card and the cookies, but don't accept the valuable concert tickets. All right, so then we have capacity and consent. So these get to a little bit more tricky. It's easy if you have the information in your head, but we should just go over it. So decision-making capacity, physician determines if the patient is capable of psychologically and legally capable of making a healthcare decision. Just as a general rule, intellectual disability and mental illness are not exclusion criteria for decision-making capacity, but there are 4 basic components for determining capacity. The first is understanding. So, what does the patient know about their condition or the procedure or the treatment that's going to occur? And then appreciation, does their condition have any significance to them? Meaning, do they understand or care that it's a bad thing to have cancer? So why is your doctor recommending this course of treatment? Reasoning, is this patient capable of weighing the options? And then finally, are they capable of expressing a choice? So you are capable, understanding, appreciation, reasoning, expressing a choice. All right, next one is informed consent. So informed consent is a process, not a document. 2-step process. This is pretty straightforward. First step is just the patient discusses the procedure or treatment with a healthcare provider. Second step is patient makes their own decision about the procedure or treatment. And then 4 components of informed consent: voluntariness. The consent is free from manipulation or coercion. Understanding, patient can understand what is discussed. Capacity, patient's able to reason or make own decisions. And then disclosure of pertinent information, including risks and benefits. All right, exceptions to informed consent. We use the wipe away mnemonic, but the exceptions to the informed consent are a waiver. Patient explicitly relinquishes right of informed consent. They are incompetent, so they lack decision-making capacity. And you can imagine in an emergency situation, there's, implied consent in those situations. Then we have privilege, withholding information. Physicians are allowed to withhold information when disclosure is determined to severely harm a patient. All right, and we already said emergency implied consent may apply. All right, consent for minors is a little bit more tricky. A minor is generally defined as a person less than 18 years old. Consent varies state by state, but generally speaking, parental consent must be obtained. Exceptions to needing parental consent are relatively few, but we remember them with the mnemonic: sex, drugs, and rock and roll. So minors don't need parental consent for contraception, treatment for STIs, or prenatal care. drugs, substance abuse, disorder treatment. Minors don't need parental consent to get that. And then emergency and trauma, minors don't need consent from their parents for that, for treatment for that. So in addition to understanding that, minors, consent for minors is really parental consent, physicians should seek to get a minor's assent, not consent, where assent is an agreement of somebody unable to legally consent. All right, so just get the minor to also agree, even though it's not legal, a legal consent. It's an assent. All right, additional situations not requiring minor parental consent is when the minor is legally emancipated, meaning legally freed from their parents. Marriage is the big one, if they're in the military or if they're self-supporting, living on their own, free from their parents. All right, next big topic under capacity and consent is advanced directives. So basically, advanced directives are instructions given by a patient for future or anticipated medical decisions. And we have both oral advanced directives and written advanced directives. Oral advanced directives are a incapacitated patient's prior oral statements used as a guide. They can be misinterpreted, which is why they're not the best, and getting written advanced directives is generally considered better, or is better. Written advanced directives are documents that specifies interventions to be done regarding potential illness or disease. For example, a living will is a written advanced directive, and then specific states have different documents. But an example of another advanced directive, written advanced directive, is medical orders for life-sustaining treatment, also called MOLST. All right, other examples of advanced directives. So in the hospital setting, when somebody's coming in and they're going to be admitted to the hospital, it is standard practice to get them to have their advanced directives on file. So the first sort of default one is full code, and full code means that you need to do everything to restart the patient's body and keep them alive. That's the default, full code. But we also have partial codes, and these are, I'm sure you've probably heard these acronyms before, but DNR, do not resuscitate, so no CPR. DNI, do not intubate, or then CMO, comfort measures only, okay? And so the important thing with these sorts of questions is if you have DNR, do not resuscitate, you can still do comfort measures. So, you limit the code to only what it says, right? Do not intubate, you could still do CPR, right? Comfort measures only, you would, not do DNR or DNI. All right, alternative decision makers. This is a good one. So power of attorney. This is a legal document where they're saying, I would like to specify a specific person to make medical decision making for the patient. And this is if they don't want to make the medical decisions or if they're incapacitated. And so in this case, patient can revoke or have the final say on the medical decision-making if they have decision-making capacity, right? So power of attorney is kind of flexible. They appoint somebody to make medical decisions for them. However, if they have capacity, they get the final say. It overrides whatever the legal document says. All right, surrogates. If the person loses decision-making capacity and they don't have advanced directive on file, then surrogate goes to next of kin. But we do have an order of priority of surrogates, and this is pretty important and very testable. So first priority of surrogate is the spouse of the patient, if they have one. Next is adult children, of the patient. Then after that, there's the parents of the patient, then adult siblings, and then any other relatives. Right? So spouse, adult children, parents, adult siblings, other relatives. All right, communication. This is pretty straightforward, but lots of questions that have to do with this. A lot about, patient-centered care, showing empathy, asking questions, finding out, what the patient wants is very important. There's stuff on motivational interviewing. So asking questions, showing empathy is kind of like the default set of answers for these types of questions. But interviewing a patient, you might have order of the following items, but basic interview setup, introduction, pronouns, ask them what the pronouns are, get at eye level with them, sit down, make sure to face patient, work with the patient to set the goals and identify their concerns, reflection, do active listening, synthesize the patient information that you get from them, validate the patient, so affirm the patient's perspective, and then recapitulation, summarize the information that they've given you, and then facilitation is allow the patient to speak freely. All right. Next is establishing rapport. So we have this mnemonic called PEARLS. And for PEARLS, the first letter P is for partnership. Work with the patient to identify concerns and preferred treatment. Employ empathy, so acknowledge how the patient's feeling and why they might be feeling that way. Apologize, take responsibility when appropriate. Respect, commend patient for coming in, having a positive attitude, and persisting in overcoming any barriers that they might have to getting care, maintaining care, etc. Legitimization, assure patients' responses are understandable or common. This is a pretty big one, right? Patient comes in, you have to ask them some uncomfortable, maybe sexual health questions, and just make it routine. You tell the patient, this is something that I ask every patient that comes in. All right, support, reassure patient you will work together and get appropriate resources. So PEARLS, partnership, empathy, apology, respect, legitimization, and support. All right, next is delivering bad news. This is a pretty big one. So we follow the SPIKES protocol, which stands for setting, perception, invitation, knowledge, emotions, and strategy. All right, so first step in delivering bad news is to eliminate distractions, ensure privacy, ask the patient who they might want in the room with them, sit with patient, allow patient to bring support, perception, determine the patient's understanding or expectations, invitation, obtain patient permission to disclose the news to them, or ask them what level of detail they would like to have. All right, so we haven't shared any information at the first part of this protocol. We eliminate distractions, ensure privacy, let them have their support, get their understanding, right? Constantly ask questions of the patients, let them tell you what they know, get their permission to disclose the news to them, what level of detail do they desire, knowledge, share the information in small pieces, allowing them time to process, and then assess understanding. This one's kind of key because there's some questions where they'll ask you something and then they bring up multiple ideas at once. Better to share the information in small chunks, one topic at a time, and allow the patient to process. All right, emotions, acknowledge patient's emotions, provide opportunities to express, let them cry, just listen. Strategy, if patient's ready, the last thing you're going to do is discuss treatment options. All right, so there'll be some questions and they'll give you say, what should you do first? What's the best initial response by the patient? It's the general wording. And if they throw strategy in there, you're like, well, that's part of the SPIKES protocol. It seems very reasonable, but that's, we don't even talk about what's going on, with the diagnoses until we've already done the setting. We've gotten to know, the patient's understanding. We've asked them how much information they would like, and then we start hitting them with some knowledge, let them express their emotions, and then finally we end with strategy. All right, so strategy comes last. What are the goals of the treatment? All right, so then we have some tricky situations. So first one, we've touched on this a tiny bit, but a family member asks for information about the patient's prognosis. This one, you'd think it's like my, father calls the hospital, wants to know how I'm doing. And unfortunately, if it's not an emergency situation, you're going to avoid discussing the information with relatives without the patient's permission. If it's an emergency situation, and you can give a status of stable or not stable. If the patient's incapacitated, you would have to confirm the family member's identity. Patient's family asks you not to disclose information to the patient, so that you have a concerned family member who's like, I know you have the results of the test. Please don't tell the patient. It'll cause them to be concerned. Generally, you would tell the patient tell the family member if the patient wants to know it, it will be told to the patient. However, if there's an exception, if the physician believes the disclosure would harm the patient, they don't have to disclose the information. All right, so if disclosure would harm patient, they don't have to disclose. Otherwise, if patient wants to know, it is up to them whether or not they receive the information, right? The patient can ask to not receive that information, but it is their health information. They have the right to know it overall, if they want to know it. All right, another one is woman has a mastectomy and says she feels ugly. In this situation, you just ask, why she feels that way, but don't give statements like you look good, right? It's just a little bit weird, kind of creepy. Don't do that. All right, patient's angry about the wait time. This is a popular practice question. Apologize, acknowledge, and shy away from explaining the delay. All right, next one is a colleague comes to work impaired. This is a potential risk. You are legally obligated to report the colleague. Generally, you'd report to their immediate supervisor, but you'd have to look at the question itself to determine what would cause sort of immediate patient safety. All right. 15-year-old girl is unresponsive and needs blood transfusion. Mom is Jehovah's Witness and refuses. This is a good one because we know Jehovah's Witnesses, it's against their religion to accept blood. So the 15-year-old girl is a minor. So the thing that's important to know here is that parents can't refuse life-saving treatments in an emergency setting. So in this case, you would transfuse the patient. All right, disease prevention is the next topic. So we have different levels of disease prevention. The first is primary, and this is just, preventing disease by reducing risks or increasing immunity. So primary prevention, give vaccines, stop smoking, do dieting, exercise to lose weight, maintain cardiovascular fitness, stop smoking, as we said. Secondary prevention is screening. So screening for early detection, so S and S. Prevent system onset is another goal of the screening. So blood pressure screen, doing a pap smear or mammogram. Tertiary prevention is treating a disease that is present to prevent complications. So, for instance, giving lisinopril for hypertension to prevent later on cardiovascular events. Give bisphosphonates for osteoporosis. And then finally, we have quaternary disease prevention, which Q would be for quit. In quaternary, so quit unnecessary medical interventions, discontinue medications that appear to be causing persistent harmful effects. The example that we see in first aid is discontinue sulfonylurea after multiple hypoglycemic events. All right, we're almost done. We have types of medical insurance plans. So these we have HMO. This is our first one that stands for Health Maintenance Organization. For this, you have limited primary care provider choice. With the exception of emergencies, you need a PCP referral. It is the most affordable with lowest premiums and lower out-of-pocket care. Then you have POS, which is point of service. Basically, for this one, you have a little bit more flexibility with point of service, can see providers out of network, but you still need a PCP to get specialist care. Point of service has higher copays and deductibles for out-of-network services. It's a combination of health maintenance organization and a PPO. The question is, what is a PPO? PPO stands for Preferred Providers Network, and you can see, despite the fact that there's preferred providers in the network, you can see providers that are out of network. You don't need a referral for seeing a specialist. The downside is because you have flexibility, you don't need the referral. You have higher copays and deductibles for all services, which should hopefully kind of make sense, right? If you are utilizing specialist care, maybe without as much of an indication, right? Because your PCP would refer you if they think you need to be referred, then there's going to be higher copays and deductibles as a result. All right, then you have EPO. This stands for Exclusive Provider Network. PCP choice is limited to the providers in the network, and the only exception is emergencies. You don't need a referral for specialist care and exclusive provider network to go see a specialist, but it has to be in that network. And it's a hybrid between HMO and PPO, just like POSs. So EPO and POS is very similar, but point of service, you do need the PCP referral. You don't need it in EPO. All right, finally, we have Accountable Care Organization. One's a little bit different. It's not actually an insurance plan because payments go through Medicare. It's only for going with providers who voluntarily enroll and specialists who voluntarily enroll. I haven't seen a question on this. HMO is the one I think that you should know the most. It's just PCPs are limited in choice, and you need the PCP referral. POS, you also need a PCP referral. HMO is the cheapest one. That's worth knowing. And PPO is also pretty common. You don't need a referral to go see specialists. Okay, so moving on to Medicare and Medicaid. Fortunately, these are pretty easy to remember based on just quick looking at how they're spelled. So Medicare with an E at the end. E stands for elderly, and then disabilities. And this is a federal social health care program. It's for patients who are 65 years or older, or if they're not 65 years or older, they have specific disabilities. The big one that gets tested is end-stage renal disease. So someone who's getting dialysis can be on Medicare, or ALS, amyotrophic lateral sclerosis, also called Lou Gehrig's disease, or they have 24 months of documented Social Security disability insurance. All right, so question 7 might say, the person has documented disability with Social Security, or just history of documented disability. Then are they eligible for Medicare if they're not greater than 65 years old? And the answer could be yes. All right, but the 65 years old, and then we have end-stage renal disease, Lou Gehrig's disease, ALS, or documented history of disability. All right, and then there's 4 parts of Medicare. Part A has to do with hospital admissions. Part B has to do with basic medical bills, so physician fees and diagnostic tests. Part C has to do with admissions and and hospice or skilled nursing, basic medical bills that are delivered by private companies, and then Part D of Medicare stands for drugs. All right, and then Medicaid with a D is for people who are disadvantaged. It's a joint federal and state health assistance program for people with limited resources or income. So D in Medicaid is for the disadvantaged. All right, very last topic is medical errors. So we have a couple of types of medical errors. We have active error. Active error is immediate impact error. So, for instance, the wrong IV dose is programmed into the machine, so it's immediate impact. That's an active error. Latent error is an accident waiting to happen. Somebody comes in, they get an x-ray of the wrong limb, but nothing has happened yet, and it could potentially be caught. Near miss is an unplanned event that does not cause harm, but has the potential to do so. But it is a near miss. Miss meaning it does get caught. So pharmacist catches medication interaction and cancels the order. And then never events, adverse event that is identifiably serious and usually preventable, but it hasn't caused significant permanent harm or death yet. So identifiably serious or usually preventable. So scalpel left in the patient's abdomen after surgery. And then a subtype of never event is a sentinel event, which is a never event. So identifiably serious, usually preventable, that has caused death, permanent harm, or severe temporary harm. All right. So identifiably serious, if it says, this person has a scalpel left in their abdomen, versus sentinel event might be this scalpel was left in their abdomen and it lacerated their kidney, and then they had bleeding into their abdominal cavity and they passed away. That would be a sentinel event versus just, there is a scalpel left in their abdomen. All right, so then last thing to mention is if there is any sort of error at all, it is the obligation of the physician to tell the patient that the error has occurred, right? You have to tell the patient that the error has occurred, even if harm did not occur, and then say, apologize and tell them that we're working on fixing it. All right, that is it. The end. And good luck on this section of step 1. Bye, guys.